My name is Leon Lenchik from Wake Forest School of Medicine in Winston-Salem in North Carolina, and I'm going to be talking about renal osteodystrophy. I have nothing to disclose. The reason I like talking about renal osteodystrophy is because it is one of the most important metabolic conditions that we encounter in radiology. The other reason I like talking about it is you really can't learn about it without simultaneously learning about three other conditions: hyperparathyroidism, osteomalacia, and rickets. So this lecture, in that sense, becomes a 3-for-1 lecture where you learn three topics while learning one. The other reason I like renal osteodystrophy is because it is part of so many differential diagnoses. So, for example, erosive arthritis that we commonly encounter in the setting of rheumatoid can look occasionally like renal osteodystrophy, or to say it a different way, renal osteodystrophy can occasionally look like rheumatoid arthritis. Either solitary lytic lesions or multiple lytic lesions, the differential include brown tumors, which are associated with hyperparathyroidism and renal osteodystrophy. Osteosclerosis and osteopenia, the differential should always include renal osteodystrophy. And finally, various mineralizations in soft tissues, including vascular calcifications, chondrocalcinosis, and tumoral calcinosis, are also something that you need to consider when you're giving differential for these findings. And finally, fracture. So what is renal osteodystrophy? Renal osteodystrophy is all of the disorders of bone and mineral metabolism associated with chronic renal insufficiency. And the reason I stress chronic is because in most cases, you will not be the first one to make the diagnosis. Both the patient and their doctors will usually know that they have end-stage renal disease. On the flip side of that, however, you will look really bad if you misinterpret the imaging findings of end-stage renal disease and renal osteodystrophy for something more serious, like a sarcoma. So let's show this first case of a 73-year-old man found unresponsive. If you read these x-rays from the emergency room, the first thing you notice is a right femoral neck fracture. So how would you dictate a case like this? You would probably say there's an acute right basicervical femur fracture, there's some hip osteoarthritis, there's some limitations, etc. But what you need to pay attention to in this case are the erosions of both sacroiliac joints that make them appear wider despite the overlying artifact and bowel gas, and the pubic symphysis, which is also eroded and appears wider. And once you've made that observation, your report should also include the phrase renal osteodystrophy, because indeed the most common explanation, and the explanation for this patient, was that the reason that his SI joints and his pubic symphysis were eroded is due to renal osteodystrophy. So that's the 3-in-1: hyperparathyroidism, osteomalacia, and rickets. It's important to recognize that osteomalacia occurs only in adults, while rickets occurs only in children. So how does this work to produce renal osteodystrophy? What happens in adults is you have an overlap between the findings of hyperparathyroidism with findings of osteomalacia. And what happens in patients with chronic renal disease is that typically the findings of secondary hyperparathyroidism are more prominent and easier to detect than the findings of osteomalacia. So for making the diagnosis of renal osteodystrophy in adults, you're going to be particularly paying attention to the findings of hyperparathyroidism. The story is slightly different in children. Before I get to children, though, let's show this case of a 51-year-old man with renal disease. On these x-rays of both hands, perhaps the only thing you appreciate are some subtle vascular calcifications. If you magnify the fingers, however, you notice bone resorption in the characteristic location, which is the radial side of middle phalanges, where the arrows are pointing. This is a classic findings in secondary hyperparathyroidism And in this case, and in this patient, they were due to chronic renal disease. Now in children, as I mentioned, the story is slightly different because there is no such thing as osteomalacia in children. So in children, the findings of renal osteodystrophy are the overlap of hyperparathyroidism and rickets. And in children, rather than the findings of hyperparathyroidism dominating, it is the findings of rickets that dominate. So if you make the observations of rickets in children, you always have to consider renal osteodystrophy as a possible underlying cause. So this 4-year-old boy with chronic renal disease has fraying and irregularity of metaphysis of both distal femurs. And in this case, the findings are due to rickets, and rickets being a component of renal osteodystrophy. So those are the 3 things that we're going to pay attention to, and we're going to begin with hyperparathyroidism. The good news about hyperparathyroidism is regardless of the cause, regardless of whether we're speaking about primary, secondary, or tertiary hyperparathyroidism, the findings on X-ray are similar. So once you learn what those findings are, and once you recognize that there's hyperparathyroidism present, then you can generate a differential diagnosis. The other good news is the same rule applies for rickets and osteomalacia. Although the causes for these conditions are many, once you learn the radiographic findings, these will be typically, not always, but typically be present in all cases regardless of their underlying cause. This in adults shows what I'm talking about. So for hyperparathyroidism, renal osteodystrophy is caused by secondary hyperparathyroidism. And for osteomalacia, the renal causes are one of many other causes, including bad diet, bad weather, malabsorption, liver disease, even oncogenic causes of osteomalacia. But once you recognize what those findings are, you can make the diagnosis. The same thing in children. Although the hyperparathyroidism in renal osteodystrophy in children is secondary, primary and tertiary findings will be similar. And although renal disease in rickets is just one of the causes, along with many others, once you make the observation of the findings, you'll be able to generate a differential. So let's start with a hyperparathyroidism and look at what the imaging findings are. The most characteristic findings are bone resorption. And bone resorption can classically occur in any of the compartments listed here. They can be subchondral or underneath articular cartilage. They can be subperiosteal or underneath the periosteum. They can be within the cortex or intracortical. They can be endosteal, trabecular, and importantly, they can also be at the insertions and attachment sites of ligaments and tendons, the so-called subligamentous and subtendinous. So let me show examples of each of these, starting with subchondral. The classic locations where erosions occur underneath cartilage would be the sacroiliac joints, the pubic symphysis, just like the case I already showed, but also the AC joints, the sternoclavicular joints, and the discovertebral junction. So here's an example of that same case. Remember the erosions or resorption underneath the articular cartilage of the SI joints and the pubic symphysis. Here's another example. Notice the calcified rejected kidney transplant in the right pelvis, but also notice that the sacroiliac joints and the pubic symphysis are eroded. CT scan in the same individual nicely shows erosions of sacroiliac joints bilaterally, explaining why they would look widened on an X-ray. CT through the pubic symphysis shows erosions around the symphysis where you lose the normal cortical definition of the joint and it looks more irregular. And finally, on a chest X-ray where the patient has chronic renal insufficiency and cardiomegaly, if you look carefully, you will notice that there are erosions of both AC joints again here due to secondary hyperparathyroidism. So the good news then is even if you only read chest x-rays and pay no attention to bones, you will occasionally encounter this diagnosis of hyperparathyroidism. And finally, we're used to looking at Schmorl's nodes on radiographs and CTs of the spine. Be a little bit careful labeling everything a Schmorl's node because occasionally you will see cases such as this where it's not one dominant erosion in the middle of the vertebra, but multiple smaller erosions in atypical locations. And this discovertebral junction erosion is again classic for hyperparathyroidism. Another fairly classic example is this subchondral erosion beneath the articular cartilage of the patella in a patient with chronic renal disease. So that's the subchondral story. The next one I'd like to show is the subperiosteal bone resorption or subperiosteal erosions, the terms that I use interchangeably. There are classic locations for this. So one I already showed, the radial aspects of middle phalanges of second and third fingers, and another which is the erosions of the distal phalanges or the tufts that goes under the name of acroosteolysis. So when you evaluate hand radiographs in all of your patients, pay particular attention to these two locations, the radial aspects of the middle phalanges of the second and third fingers. And if you do that, such as in the case here, you will recognize that the second and third fingers have a eroded appearance compared to the more normal looking fourth finger. And this will allow you to make the diagnosis of subperiosteal resorption and then suggest the diagnosis of hyperparathyroidism. Another classic location for subperiosteal bone resorption is along the medial metaphysis of the tibia, as is shown on the image on the left. A less common location is the location in the proximal humerus, shown on the right. Acroosteolysis is shown here. This is where the distal tuft is eroded. You can see that in the hand, as is shown here, or you can see it in the feet in two separate patients, as is shown here. Another characteristic and classic finding of hyperparathyroidism. Moving on to the next compartment, the intracortical and endosteal bone resorption. Unfortunately, this finding is so common that seeing it by itself is unlikely to lead you to the diagnosis of hyperparathyroidism. A much more common explanation would just be an elderly individual with osteoporosis. But nevertheless, I think it's important that you understand that all of the compartments of bone are typically resorbed in patients with hyperparathyroidism. Moving next to subligamentous and subtendinous bone resorption. Now, these findings are classic, and the locations in which you should look for them include inferior margin of the clavicle, the humeral epicondyles, the ischial tuberosities, the femoral trochanters, the superior pole of the patella, and the location of the calcaneal enthesophytes. Show you an example here at an elbow. You can see a marked resorption of bone along the lateral epicondyle of the elbow in somebody with chronic renal disease and secondary hyperparathyroidism. And this is a radiographs of the pelvis. The left hip fracture should be obvious to you, but the arrows are pointing to the subtendinous resorption of the ischii, where the hamstrings attach, the resorptions on the trochanters, where the gluteal tendons attach, and the resorption along the anterior inferior iliac spine. By the way, this patient also has erosions of the SI joints and pubic symphysis, but we covered that already. So a lot of times the findings are such as in this case, they're generalized bone findings, which is actually great because it makes the diagnosis easier to make. Another classic location for subtendinous erosions are at the insertion of the Achilles tendon on the posterior calcaneus, shown here in 2 separate patients, and at the attachment of the plantar aponeurosis on the plantar calcaneus, also a classic location of subtendinous bone resorption in 2 separate patients with chronic renal disease. Next and final are the trabecular bone resorption, and here 2 patterns are seen. The first pattern is really limited to the skull, and it has the characteristic appearance of salt and pepper. So the salt is the normal bone, the pepper are the resorbed bone cavities that are due to hyperparathyroidism. When these collections get larger, as they frequently do in the extremities, these focal lytic, and when they're healed, sclerotic lesions go under the name of brown tumors, and these are basically large collections of osteoclasts resulting in marked resorption of trabecular bone. Example of what salt and pepper skull looks like here on the wide view and on a cone down view, and here a more dramatic example. And again, the pepper portion are the resorbed bone cavities that are due to hyperparathyroidism. And this is a large lytic lesion in the proximal humerus, so this, of course, has a wide differential, but in this particular case, it was fractured, but the lytic lesion itself was a brown tumor in a patient with long-standing chronic renal disease and secondary hyperparathyroidism. And here's a much smaller brown tumor in the finger. The calcified mass in the adjacent finger is another common feature of renal osteodystrophy called tumoral calcinosis, and we'll address some of these findings a little bit later in the talk. So that's the story on bone resorption with hyperparathyroidism. A lot of different compartments involved, and you may be asking yourself, are we done yet? Well, there's 2 other compartments of bone to talk about. One is the marginal erosions that occur at the interphalangeal joints, and the second is the erosion of the lamina dura of the mandible. So this is a 44-year-old woman with type 2 diabetes who was unfortunately non-compliant and developed end-stage renal disease. Her baseline radiograph is shown on the left. Her radiograph 2 years later is shown on the right. Note the marked increase in vascular calcifications in such a short amount of time in such a young individual. Also note the yellow arrow pointing to a marginal erosion around the IP joint of the great toe, a finding that would have a differential that includes gout and rheumatoid arthritis and other erosive arthropathies. But if you know the history as you do here, the finding is most likely due to secondary hyperparathyroidism. So this differential, or remembering to include hyperparathyroidism in the differential diagnosis of erosive arthropathy, is very important. Lamina dura is the interface between the teeth and the mandible. It is cortical bone, and in patients with secondary hyperparathyroidism, that cortical bone that is partly responsible for holding the tooth in place, for forming the gum fossis or the joint of the tooth, gets eroded. It's difficult to see on this plain radiograph, but if we look at the CT, the yellows are pointing to the resorption of the lamina dura around the teeth. Another classic, although not a very common finding, of secondary hyperparathyroidism. So remember, all the different bone resorptions that I just showed in all these different locations in the bodies will be seen not just in patients with chronic renal disease, but occasionally will also be seen in patients with primary hyperparathyroidism. So let's move on then and talk about osteomalacia and rickets, keeping in mind that this is really the same disorder with 2 different names. So rickets and osteomalacia are a group of disorders characterized by incomplete mineralization of osteoid tissue. Rickets is a disorder only seen in growing bone, and all of the findings are at the growth plate. Osteomalacia is a disease that is only seen after skeletal growth is complete. The growth plate is not involved, and the hypomineralization occurs in both trabecular and cortical bone. So what are the findings of osteomalacia? The most common findings is generalized osteopenia. But unlike the osteopenia that is due to menopause or aging, the classic appearance of this osteopenia is the trabecula become indistinct or more fuzzy. Occasionally you also see looser zones, which are essentially insufficiency type fractures through osteomalacic bone, which are typically bilateral and symmetric and typically involve either the femoral neck, the proximal ulna, the axillary margin of the scapula, the pubic rami, or ribs. Osteomalacia also leads to softening of the bone, so occasionally you will see skeletal deformity, in particular at the spine and at the skull. So this is an individual with osteomalacia. The finding here is that the trabecular are indistinct. That is a very difficult observation to make. Just to contrast it with the finding of the eroded left sacroiliac joint and the pubic symphysis, the findings that here are due to hyperparathyroidism are much easier to detect. So when I said earlier that in renal osteodystrophy in adults, the findings of hyperparathyroidism trump the findings of osteomalacia, that's what I was speaking about. It's typically going to be easier to make the diagnosis based on these characteristic erosions rather than based on the indistinct trabecula. What about rickets? Once again, with rickets, the most common findings are generalized osteopenia. But the key findings that are going to allow you to make the diagnosis are located at the growth plates. The growth plates can be increased in lucency, they can be widened or elongated, they can be irregular or frayed, as I already showed in an earlier case, and if progressed for a long time, they can result in a cupped appearance of the metaphysis. The most common locations for the findings of rickets are the costochondral junction in the ribs, sometimes called the rachitic rosary, the distal femur, both ends of the tibia, distal ends of the radius and ulna, and proximal humors. Skeletal deformity is also a common feature of rickets for the same reason it is in osteomalacia, because the bones are softer. So in neonates, you can get flattening or squaring of the skull. In early childhood, you can see bowing of the arms and legs. And in older children, you can see scoliosis, basilar invagination of the skull, or the so-called triradiate deformity of the pelvis. Another common feature of rickets is slipped capital femoral epiphysis. Here's an example of what a widened, frayed, and cupped metaphysis looks like at the distal ulna. Here's another example of widening, fraying, and cupping of the metaphysis here in the distal femur. Both findings of rickets. And here, with an MRI correlation, the arrow is pointing to widening and irregularity of the growth plate, again, in a child with rickets due to chronic renal disease. And this is bowing of the tibia, and the arrow is pointing to an insufficiency fracture, again, in a child with long-standing chronic renal disease and associated rickets. So the same good news apply in rickets and osteomalacia. Once you recognize these findings that are mainly at the growth plate, you're going to be able to make the diagnosis, and then you can start to deduce the etiology. And in a lot of cases, it'll be due to chronic renal disease, but other causes are possible. So again, I've said this point many times, but it bears repeating. When you speak about renal osteodystrophy in children, the findings of rickets dominate, while in adults, the findings of secondary hyperparathyroidism dominate. Those are the 3-in-1 lectures that I promised. But before we stop, there is one other point that needs to be made. And that point has to do with soft tissue mineralization. Because in patients with renal osteodystrophy, in particular in adult patients, these findings are particularly common. They include vascular calcifications, they include chondrocalcinosis or calcification of cartilage, and most importantly, they include these large collections of mineral around joints called tumoral calcinosis. So these are hand radiographs in somebody with chronic renal disease. Notice the calcified collections around multiple joints of the hands. This is a classic appearance of tumoral calcinosis. Another example here at the elbow, multiple large calcified masses, some of them with some fluid levels, classic of tumoral calcinosis. Same observation here around the shoulder joint. Same observation here around both hip joints. And finally, same observation here, seen on a chest radiograph, around both shoulder joints. This is tumoral calcinosis in a patient with chronic renal insufficiency. The last thing I want to talk about before we stop is this observation that when we speak about hyperparathyroidism, osteomalacia, and rickets, we're typically seeing not enough mineral on X-ray. So the bones typically appear osteopenic. But on the other hand, in the soft tissues, we have too much mineral, whether it's located in the blood vessels or in those large collections called tumoral calcinosis. So it seems like mineral is leaving the bone and arriving in the soft tissues. But that story is somewhat incomplete, because if you look at these two x-rays of the lumbar spine, the one on the right is clearly osteopenic, whereas the one on the left, you can make an argument that the bones are actually increased in density. The interesting thing is that both of these patients have long-standing chronic renal disease. So the last finding that we need to be aware of when we're speaking about renal osteodystrophy are these increased deposits of bone that in the spine go under the name of rugger jersey spine, where the end plates appear more sclerotic than the mid portion of the vertebra. But you can get a more generalized sclerosis as well. So here it is shown on a sagittal CT of the lumbar spine. Notice the discovertebral junction erosions that I already showed earlier. But the reason I'm showing this case here is notice the band-like sclerosis that occurs at the superior and inferior margin of the vertebra, giving the so-called rugger jersey appearance. So we're having increased in mineral in the bone rather than decreased. Here's a thoracic CT, again in a sagittal reformats, showing the rugger jersey appearance of the thoracic spine, and also showing the erosions here at the sternomanubrial joint, another location that I didn't speak of yet for subchondral erosion. And finally here in the cervical spine, again, a rugger jersey appearance that has progressed long enough where the bones almost look diffusely sclerotic rather than diffusely osteopenic, a relatively common appearance of renal osteodystrophy. So we've just about reached the end. This is the summary slide that attempts to capture all the salient features of renal osteodystrophy that I spoke about thus far. The ring on the left is the hyperparathyroidism ring. The key finding in this condition is resorption everywhere. But occasionally, as the cases with which I concluded, you will see bone sclerosis, and when it occurs in the spine, it may have that characteristic rugger jersey appearance. The ring on the right is the osteomalacia-rickets complex. With osteomalacia, I mentioned that indistinct trabecular are difficult to recognize, and rickets, where I emphasize the findings that occur at the growth plate, and I also emphasize the deformities that can occur. And the ring on the bottom is the third ring that allows you to make the diagnosis, particularly in adults with chronic renal insufficiency, and that includes vascular calcifications, chondrocalcinosis, and most importantly, these large collections around joints, which are called tumoral calcinosis. So the renal osteodystrophy story is interesting to me for many reasons. And if you happen to be a resident who's trying to enter the profession, I think when you generate your differentials and you're discussing cases of erosive arthritis, or you're discussing lytic or sclerotic lesion or lesions, when you're discussing osteopenia or diffuse sclerosis, and when you're discussing various mineral deposits in soft tissues, and even when you're discussing insufficiency fractures, please don't forget metabolic bone disease and one of the most important conditions in the umbrella of metabolic bone disease, which is renal osteodystrophy. Thank you.